So my name is Santana Reyes, and I will be talking about the rehabilitation and treatment of an acute Achilles tendon rupture. So general introduction, this is an Achilles tendon. It's a diagram, obviously, but the Achilles tendon is the primary plantar flexor in the ankle and foot, and it's also the strongest and longest tendon in the human body. It's formed up by the distal tendons of both the gastroc and soleus. You can kind of see the soleus in here, but it's just a diagram. We'll get to nitty gritty right here. So, like I said earlier, it is comprised of these two muscles. The gastroc has a medial and a lateral head that both originate up in the medial and lateral femoral condyles. And that kind of plays a role later, and we'll see in biomechanics, but that assists in knee flexion of the leg as well. So, moving away from just general anatomy, this is an injury. So, an acute Achilles tendon rupture is generally classified as a sudden pop or a pull of the tendon. And it's commonly accompanied by a feeling of being kicked in the back of the leg. It's usually a sharp pain, and it's pretty loud when it happens. These acute ruptures occur when that tendon is lengthened and it has to absorb force and blow. So like when you're landing, trying to explode off of like a first step, when you're dorsiflexing and that tendon is lengthened, that's a pretty common mechanism for it to happen. So here is, I know it's a little blurry, but this is just an intraoperative photo of it. So right here you can see the distal segment of the Achilles tendon and then the superior segment of the Achilles tendon. And it's a little bit clearer on the laptop right here, but you can tell like when it ruptures, it's pretty severe, kind of gets all over the place, and kind of makes it a hard time for surgeons to find the right pieces, and depending on that surgical intervention, go about how they want to recreate or make it all go back together. So with these MRI images, this is a subacute, so this is about 3 days after it first happened. You can see in this top image, there isn't any clear defined Achilles tendon. It's kind of all just fuzzy and blurry up here. And then in this second image down here, you can see a more defined Achilles tendon, and then this large white mass right here, that's fluid that has came in and kind of like our swelling, like our edema. That's where this takes place after that rupture has occurred. Now this bottom image also displays thickened pieces of the Achilles tendon, and that's primarily due to previous tendinitis. That's why they kind of inflame, not really too linear, kind of swollen out just a little bit. So moving from the MRI images, from all the anatomy stuff, we're going to go to my overall purpose, like why I chose the Achilles tendon, why I think it's important. Well, the Achilles tendon rupture is an increasingly common injury, especially in those who are like ages 30 to 40. So think your older professional athletes who still want to compete at a high level, but their body is starting to slowly go on that decline. It is 5 times more popular in males, and I thought that was a very just interesting random fact. But the Achilles tendon also serves as a primary structure in enabling proper gait mechanics such as walking, jogging, sprinting. That's as far as gait is concerned, and then cutting and jumping, and all of those actions are very vital and important in different sports. Also, this mechanism is also easily reproducible, so think when you jump, land, and you want to go somewhere after, it's just easily reproducible, and it's pretty common throughout all sports. So moving towards a biomechanics approach, the foot, ankle, and lower leg are all comprised of multiple joints that work together to absorb shock, to distribute weight, and stabilize the rest of the body. Now, the Achilles tendon also functions as an ideal mechanical lever that pulls the calcaneus, that works onto the gastroc and soleus, and that all disperses force and tries to just balance everything out as you're going through loads, as you're trying to push, pull, And so this allows for the tendon to pass weight distribution, shock absorption throughout the whole lower extremity without any pain, ideally. So continuing kind of like what I alluded to earlier, the knee flexion is also very important in all sports and walking. And that's where the upper insertion of that gastroc comes into play. And it also provides crucial roles in walking and sprinting, as they stated previously. But the knee, ankle, and foot, along with the Achilles tendon, must all work effectively together to produce force and power in different exercises and sports. So, like I stated earlier, walking gait patterns are pretty important in all sports and in life. You can see the Achilles tendon also has to work with both, it has to work with and against antagonist muscles, like the tibialis anterior, which is right here. And its primary action is to dorsiflex that ankle. And if the Achilles tendon is too tight, that might disrupt how the tibialis, how much dorsiflexion you can get in, and that can limit how much you can, like how deep you can squat, kind of stuff we learned in kines as far as body positioning throughout different lifts. But like I said, it has to work kind of wave, and like Achilles tendon has to come into play, tibialis anterior has to come into play, but they kind of balance each other out throughout different phases of gait. So you have dorsiflexion as it loads, then you have the Achilles tendon coming up with plantar flexion, and just all that stuff has to really work together to produce good quality movement. So just like walking, sprinting is another phase-by-phase approach that these two muscles and tendons have to work together for. But these sprinting patterns can still be affected by like predisposing issues, misalignments, stuff like that. The Achilles tendon also must mediate the force that's produced from the upper body, the torso, the hips, and the upper legs, so like the thighs. And if any imbalances or problems lie in there, like imbalances, stuff like that, you'll usually see pain come through in this phase specifically. People might not have pain when they're walking, but with pain like a tendonitis when you're trying to sprint and you're trying to jump, this is where you'll see it. So kind of moving towards that predisposing factors, we have foot orientation. So that's primarily rear foot and forefoot valgus and varus. And these different positions all place stress differently along the foot. Now, all these stresses combined with the repeated jumping, repeated sprinting, and cutting, all of that combined may irritate tendons, especially if the foot isn't in its proper, normal, neutral state. So going from a foot orientation perspective, moving to a leg length discrepancy. Now, when we talk about abnormalities with weight shifts, so you can see here, if we have tilted hips and knee rotated and arch drops, if we have that postural abnormality or defect that's been a habit for like weeks, months, years, you can see how that can wear on the body. With knees specifically, it can develop like arthritis if you're in this position, or like if you have a leg that's actually longer than the other. That's where Greg comes into play, and he does all of his hip magic, kind of tries to get that done. Whereas if you see a balanced position like this, you have better body mechanics during activity, you feel less likely to, or you're generally less likely to create muscle imbalances that may also lead to strains of muscles in sport. So moving towards etiology and pathology of the ruptured Achilles tendon. Common mechanisms, like I said earlier, are like a sudden stop, and a sudden load while the tendon is maximally lengthened, so like in that dorsiflex position. And then as far as pathology goes, the lower extremity function is very limited after injury, as you can't really, when the Achilles is ruptured, you can't push off, you can't get into that toe up phase. So most athletes that do undergo this injury have trouble getting off the court, they need help, and they can't plantar flex their foot. They kind of just hobble over on their heel. So going to my specific case, a male basketball player, professional male basketball player, attempted to drive towards the basket. He took one explosive step, and then he felt that same pop, that same kick in the back of the leg. And he was also unable to plantar flex that foot, and he needed help getting off the court. Initial care consisted of an eval by the head athletic trainer at the time at that game. They took him about 5 minutes to get to that locker room where they assessed him via a Thompson test and palpation, just for that general eval in that locker room. So a Thompson test was used to assess the integrity of that tendon. And we'll get into that with the next slide. But palpation also produced, like as he was palpating distal calf, you couldn't feel really any fibrous band, tissue, anything in there, but he did feel two different like kind of knots towards the superior and inferior points of where the Achilles should be. So we'll kind of get into that right here. So in the top image, you have a negative sign, so squeezing the calf reproduces that plantar flexion, and then a positive sign for the Thompson test would be squeezing that calf and producing no plantar flexion. So as far as clinical assessment goes, they used MRIs like seen in that anatomical picture, and they were used, and later that night, the surgeon decided that he wanted to do an open Achilles tendon reconstruction, and we'll kind of get into that right here. So this is an intraoperative open Achilles tendon image, and you can see a large incision is made. They kind of fold back that tissue, and then as you can see right here, it's just the ruptured Achilles tendon just right there. And you can see it's pretty tough. Like one issue that we had as far as rehab went is we're trying to make sure that that tendon isn't lengthened too much or shortened by surgical intervention, because as soon as you get lengthened or shortened tendons, that kind of affects how we go about like plantar flexion compared to the other leg. So this is just another diagram of that same open Achilles tendon surgery. So plans and goals of rehab and treatment. Phases were used. It was a 5-step approach, 5-phase approach, I should say. But phase 1 was acute post-op. So the athlete had the MRI the night it happened. He had surgery the next morning, and immediately after that, he was placed in a moon boot. I don't really go into that right here. I didn't know this a whole bunch of things. But a moon boot is pretty much like one of our regular ankle boots, but it's placing the ankle in a plantar flex position to kind of alleviate, to stay away from that dorsiflexion. Now, phase 1 included weight bearing with the brace with crutches and monitoring pain and decreasing swelling. We also wanted to achieve active range of motion out of the brace, but not anything dorsiflexion related. And that lasted about 2 weeks. And then we move into phase 2, which is a protection phase. And this is really just us trying to prevent any infection along with phase 1, infection and atrophy of that lower extremity. But these goals still included maintaining hip and general knee range of motion, as well as decreasing overall risk of re-rupture, and that's the same throughout all phases of rehab. Phase 3 included, phase 3, which was weeks 7 through 9, included normal range of motion in all planes, especially dorsiflexion. And we wanted to normalize gait patterns. This is where I kind of implemented aquatic-based rehab, just so we could get weight bearing sooner, so we can still weight bear, but kind of alleviate overall load onto that foot. Moving into phase 4 and 5, these are kind of more advanced. These are weeks 10 through 18. But the goals here were full active range of motion, full passive range of motion, and full resistant range of motion, along with full weight bearing with no crutches or boots, and 75% of strength compared to the uninvolved leg. And that was assessed through leg press, single leg, hopping, and girth measurements. So going to phase 5, goals included 90% of overall strength compared to the other leg, and continued girth measurements that were within 1/2 of a centimeter of the uninvolved Another emphasis here in phase 5, in phases 4 and 5, we're normalizing gait patterns while walking and sprinting as well. So returning to play physically, the athlete was able to return to play after 8 months of rehab. The athlete was also had to reach these goals below, and those goals were full range of motion in all planes, functional strength of the affected limb compared to the other limb, balanced proprioception within normal limits, so like base testing prior to overall activity, kind of getting back to those levels, as well as no observable change in gait and grip measurements that were similar for both sides. Psychologically, I think it was important to implement this just from our classes, or our class with Laura. So he underwent significant challenges in regards to being separated from the team, just not really traveling with them either as he was out. And he had, throughout phases like 3 and 4, there were consistent muscular imbalances. Like I said earlier with that tibialis anterior and that dorsiflexion, we kind of had issues with how we want to go about creating that normal functioning range of motion. And then cognitive exercises were used to help reduce tension, improve confidence. So these were self-talk, imagery, goal setting, and reframing. So like reframing perspective. Now, in conclusion, the Achilles tendon I felt is pretty important to the body. It is still one of the strongest, most important tendons of our body, allowing us to walk. When it's ruptured, it poses a significant return to play protocol for the athlete, both mentally and physically. But going through a proper and accelerated rehab protocol through aquatic fitness and training can get the basketball player back around 8 months post-op. Any questions?
Why open versus closed repair?
Well, we chose open because it allows for the surgeon to clearly get rid of all scar tissue, to have clear visual